Today, we're fortunate to have with us Dr. Ameesh Parikh. He's a St. Jude Medical Group. He's an interventional cardiologist at St. Jude Medical Center. He has an interventional cardiology fellowship at Kaiser Permanente, cardiovascular disease fellowship at Kaiser Permanente. He did his internal medicine residency at the University of California, Los Angeles. He's a graduate of the Rosalind Franklin University Medical School in Chicago, Illinois. He did his bachelor's degree in neuroscience at UCLA. He's board certified by the American Board of Internal Medicine. He has passed his boards in cardiovascular diseases, cardiovascular interventional cardiology, and nuclear cardiology board. So please welcome Dr. Parikh.
Thank you, Joe. Thank you for having me. So I was asked to give this talk today to you all regarding cardiovascular risk factors, which obviously is a very broad topic, but I'll do my best. I do not have any conflicts of interest to report. So before we talk about cardiovascular risk, we have to understand the burden of cardiovascular disease in this country. And the scope of the problem is such that back in 1990, ischemic heart disease, which is what we refer to when we talk about atherosclerosis, coronary artery disease, heart attacks, things related to blood flow to the heart, being fifth in leading causes of death and disability, and cerebrovascular disease, predominantly strokes, being sixth. And this represented over 3% and nearly 3% for those diseases respectively. By 2020, ischemic heart disease is expected to be first, nearly 6%, and strokes fourth at just under 4.5%. So these are major global problems. So what are the risk factors for these diseases? There are several, but the ones that we predominantly target in medicine are blood pressure, cholesterol, diabetes, and smoking. And those are the things that I want to talk about the most today. So we can't really talk about our understanding of cardiovascular disease or its risk factors without mentioning the Framingham heart study. This is the pioneer study and the largest running cardiovascular disease study in the world. This was how we basically gained our understanding of these disease processes. It started back in 1948 with over 5,000 patients. They were aged between 30 and 62. They were examined twice a year, and the study still goes on today. The majority of the original patients have passed away, but over 5,000 of their offspring are still being looked at and were enrolled back in 1971. And in fact, they're still enrolling third generations of these original cohort of patients, which is so far is over 3,500 of their grandchildren. And these folks are followed for cardiovascular disease events, and these events are reviewed by a panel of physicians. So some things we've learned about this study is lifetime risk. So by the age of 40, men have a remaining lifetime risk of coronary heart disease, so ischemic heart disease, of nearly 50%, and women over 30%. By the age of 70, there's still a lifetime risk for men of nearly 35% and under 25% for women. So there have been some significant milestones during this study. In 1960, it was discovered that smoking increased risk of heart disease. A year later, cholesterol, blood pressure, and EKG abnormalities were also found to increase risk. By 1967, it was discovered that physical activity would reduce the risk of heart disease, and obesity will increase risk. In 1970, high blood pressure was found to increase the risk of stroke and is one of the most powerful risk factors for stroke. In 1976, menopause was found to increase the risk of heart disease in women, which translates to being premenopausal is protective. In 1978, psychosocial factors were found to affect heart disease. And by 1988, it was discovered that HDL cholesterol, or good cholesterol, reduces the risk of death. In 1994, we understood that an enlargement of the left lower pumping chamber of the heart, we call the left ventricle, which is the meat of the heart. It's what pumps oxygenated blood to all the vital organs. When it's enlarged, it increases the risk of stroke. And in 1996, we began to describe the progression from hypertension, which is high blood pressure, to the very serious and very common effect that it can lead to, which is heart failure. So this slide essentially shows us a 10-year coronary heart disease risk in the Framingham study, looking at 55-year-old adults. And what you can see is that if you start with a patient in column A that has really no significant risk factors other than maybe age, so a normal blood pressure, a normal total cholesterol, a good HDL, lack of diabetes, lack of smoking, the risk is low for 10 years. You're talking about 5%. And that risk is pretty much equal in men and women. But as you add on increased blood pressure and increased cholesterol, you already start to double that risk in men, more than double, and increase the risk by a few percent in women. As you add on a low HDL and then progressively diabetes and cigarette smoking, you can see this exponential growth of risk in both men and women. This is a similar slide from the Framingham study that looks at 10-year risk for stroke, also in 55-year-old adults. Slightly different risk factors looking at blood pressure, diabetes, cigarette smoking, prior atrial fibrillation, which is the most common arrhythmia that we see in cardiology. It's related to hypertension and age. And the biggest concern with atrial fibrillation is that it is a powerful risk factor for stroke and any prior cardiovascular disease. So again, you can see that patients who lack risk factors, their 10-year risk is very low. But as you add on these risk factors, there's an exponential growth in risk. So these risk factors are very powerful, and the Framingham risk study demonstrated that. So if we talk individually about these risk factors, let's start with hypertension. So obviously this is an exceedingly common diagnosis. And the definition of hypertension is a sustained elevation of blood pressure. Specifically, when we see the top number or systolic pressure equaling or surpassing 140, and likewise with diastolic blood pressure or the bottom number meeting or exceeding 90 millimeters of mercury. So a lot of times doctors and patients don't speak the same language. So when we speak the same language, we want to understand how to interpret what's normal or abnormal blood pressure. So less than 120 systolic and less than 80 diastolic pressure is normal. In fact, because we want to raise our awareness of the risks of high blood pressure and also be more proactive in preventing its progression, we tend to think of blood pressures between 120 and 139 over 80 to 89 as pre-hypertension. And the purpose of that is not necessarily to institute medications, but to institute lifestyle modifications such as diet and exercise and weight loss. By the time you get to the threshold by the definition I mentioned, then you're talking about full-blown hypertension. When the numbers exceed 160 and 100, then that's the second stage of hypertension, and that carries the greatest risk. So in patients who are over the age of 50, we find that the top number of systolic blood pressure is generally more important as a cardiovascular disease risk factor than the diastolic pressure. And in fact, if you start with a normal blood pressure of 115 over 75, with each incremental increase in blood pressure by 20 over 10, you double your cardiovascular risk. So if you think about that, a patient who is averaging 135/85 blood pressure has double the cardiovascular risk of a patient who averages 115/75. So we can classify hypertension in two ways. Primary hypertension, which is 90 to 95% of our patients at least, we call that often essential hypertension. And it basically means that we don't have a specific cause. It's rare that we diagnose secondary hypertension. We say 5 to 10% in adults. It seems that in clinical practice it may be less, but that's when there is a specific underlying medical condition that's secondarily raising the blood pressure. In that case, we want to treat the underlying condition. So there are risk factors for developing high blood pressure. Age and gender certainly is one, in that men are at risk for high blood pressure at 55 and women at 65. Not that we don't see it younger than that, we often do, but that's the main risk factor when we talk about age and gender. Alcohol can raise blood pressure, and most often in moderate to heavy use, but it is a known factor. Cigarette smoking does affect arteries in ways that can raise blood pressure, and similarly, so does diabetes and high cholesterol. So not only do those risk factors increase risk for cardiovascular diseases, it increases the risk of having high blood pressure itself. Similarly, we tell patients with high blood pressure to restrict their sodium. Well, excess dietary sodium can potentially raise your blood pressure as well. A family history is definitely a risk factor for hypertension. We see many young patients develop hypertension when they have a strong family history of it, particularly at a young age in their first-degree relatives. Certainly being overweight increases risk, and ethnicity can play a role. Certainly African Americans have the highest prevalence probably of hypertension. Being sedentary increases the risk. Being active obviously can promote weight loss and reduce the risk of developing high blood pressure. Socioeconomic status plays a role for a multitude of reasons. Obviously, patients who have less access to education or less financial means may not eat as healthy, may not be as aware of the importance of lifestyle choices, may be forced to make poor choices for various reasons, and all those things can increase risk. And stress definitely does raise blood pressure. So, unfortunately, when it comes to hypertension, we do call it the silent killer. So, we all know that every time you go to a doctor's office, they check your blood pressure. You go to a Walgreens or a CVS, they might have a blood pressure machine there. It's so important that it's just widely available and widely done. And it's not something that you're necessarily going to feel. So most people are asymptomatic unless it becomes very severe, either acutely or chronically, or starts to cause damage to organs. And in those cases, you can develop fatigue, reduced tolerance to activities, dizziness, palpitations, shortness of breath, or chest pain. So some of the main complications we worry about with hypertension and cardiovascular disease obviously is the development of atherosclerosis. Some people refer to that in layman's terms as hardening of the arteries. Basically, you can see in this cartoon of a cross-sectional artery that there are three different layers to an artery, the outer layer being the adventitia, the middle layer the media, and the inner layer the intima. The intima is comprised of endothelial cells, sort of like the cells in the surface of your skin, if you will. And when there's damage to that inner lining of the artery, then muscle cells can proliferate or divide, and lipids can get deposited, and that creates a plaque. The fibrous plaque has elastic and collagen fibers that protect it and cover it. If that cap were to break, then a clot could form, and that is the mechanism of a heart attack. Over time, these plaques can become complex because of dead tissue, bleeding into the plaque, clot formation, and calcification. So, hypertension can cause what we often refer to as hypertensive heart disease, which can mean different things to different people. But the effects of high blood pressure on the heart can lead to coronary artery disease, like I just explained. It can cause thickening of the pumping chamber of the heart, the left ventricle, which we call left ventricular hypertrophy. Hypertrophy of the left ventricle is different than enlargement. I mentioned before that enlargement of the left ventricle increases the risk of stroke. Enlargement means that the cavity where the blood sits gets dilated so that the space occupying area of the left ventricle where the blood sits is larger. In left ventricular hypertrophy, the muscle that contracts is thickened, much like when we lift weights and our biceps, for example, might get thicker over time. As the heart pumps blood against a high pressure, it can thicken. And ultimately, hypertensive heart disease leads to heart failure. When we lower blood pressure effectively, we can reduce the risk of stroke by 35 to 40%, the risk of heart attack, which we call myocardial infarction in medical terms, by 20 to 25%, and heart failure by as much as 50%. This slide just demonstrates the logarithmic or exponential incremental increase in risk of stroke and coronary heart disease based upon higher blood pressure readings. You can see that the highest level of blood pressure in this slide has a nearly fourfold increase at 175 over 105 compared to a person averaging 148 over 91, and probably close to a 12-fold increase compared to a patient with a close to normal blood pressure of 123 over 76. The risk of stroke is slightly greater with hypertension than the risk of coronary heart disease, but you can see on both graphs that they're each increased. So this is looking at blood pressure and congestive heart failure. Again, looking back at the Framingham study. So what this slide shows us is different age groups from the 30s to 40s all the way out to the mid-60s to mid-70s. And certainly you see some varying levels of risk in patients who lack high blood pressure, which is the yellow bars. But overall you can see that those risks are low. But you add high blood pressure, and across the board there's a dramatic increase in the average annual rate of development of congestive heart failure. So this is a very powerful risk factor for heart failure. And obviously that risk is highest in the eldest of patients, but it is high and substantially higher than the normal tensive or normal blood pressure patients across the board. So this is another slide, again looking at risk of cardiovascular events based upon specifically systolic blood pressure. I mentioned before, systolic blood pressure seems to be the more powerful indicator of cardiovascular risk compared to diastolic blood pressure. And this essentially is showing that same phenomenon. As you can see, greater events with higher blood pressure readings, and that's seen in both men and women. This is another slide looking specifically at men and specifically at isolated systolic hypertension, specifically greater than 160, so stage 2 hypertension. And in these men, they were middle-aged between 45 and 54. And you can see the dramatic difference from the orange bar to the yellow bar in having or lacking this kind of stage 2 systolic hypertension. And these patients, again, are coming from the Framingham study, and this is a 24-year follow-up. So the bottom line, hypertension is a very big target for us to prevent all forms of cardiovascular disease. So let's talk a little bit about cholesterol. To understand cholesterol and its targets, we have to know a little bit about how it works. So there are particles in our body called chylomicrons. These particles transport fat that we ingest from our diet from the intestine and takes it to the liver. In the liver, the chylomicrons release triglycerides and some of its cholesterol, and they become low-density lipoproteins. We refer to these as LDL. Okay, this is the bad cholesterol when we check your cholesterol level. That LDL then carries fat and cholesterol to the body's cells. That's bad. We don't want that. High-density lipoproteins, or HDL, carry fat and cholesterol from the cells back to the liver to be excreted. That's good. We want that. So when oxidized LDL cholesterol levels get high, then they can form atheromas. That's that complex plaque I showed you in the other slide. HDL cholesterol is able to remove that cholesterol from that plaque. So there are other atherogenic cholesterols, such as very low density lipoproteins or intermediate density lipoproteins, but the main focus for us in cardiology is the LDL. So this is another cartoon cross-sectional slide of an artery, again showing you those three layers, showing you a plaque that's embedded in the wall of that artery, which is atherosclerosis, and if that fibrous cap thins and breaks, we call that plaque rupture, and that's what can either heal with calcium or get affected by formation of clot and lead to a heart attack in the case of the coronary arteries. If it happens in the case of arteries to the brain, it can lead to a stroke. So I like this slide. I think a lot of people would appreciate it. It's looking at different types of fats and how they can play roles with HDL and LDL. So your unsaturated fats have desirable effects. Those are mono and polyunsaturated fats because they lower LDL, which is good, and they raise HDL, which is also good. So for the monounsaturated fats, that includes your olives, olive oil, canola oil, peanut oil, cashews, almonds, peanuts, and most other nuts, as well as avocados. Polyunsaturated fats can be found in corn, soybean, safflower, and cottonseed oil, and fish. The saturated fats are undesirable because while they do raise HDL, they also raise LDL. And LDL is one of the leading causes of atherosclerosis. So saturated fats are found in a lot of dairy products. That includes whole milk, butter, cheese, and ice cream. Also found in red meat, chocolate, which obviously is dairy, coconuts and coconut milk and coconut oil, the yolk in eggs, and the skin on chicken. But trans fats are the worst because all they do is raise LDL. And those are the things we really want to avoid. They're found in most margarines, vegetable shortening, partially hydrogenated vegetable oil, deep fried chips, many fast foods, and most commercial baked goods. There are some familial forms of high cholesterol. Don't want to get into that too much, but this tends to cause unusually high levels of lipids than we would normally see in most patients. So what are the goals? So the optimal LDL is less than 100. That's the goal for patients who have coronary heart disease or an equivalent. 100 to 129 is near optimal and acceptable in most patients that don't have coronary heart disease or an equivalent. 130 to 159 is borderline, 160 and above is high, and greater than or equal to 190 is very high. There are some numbers here for total cholesterol, but sometimes that can be misleading. I've had some patients, more often women, who might have extraordinarily high HDLs, like over 100, and therefore their total cholesterol will be high, but their LDLs are optimal. So certainly total cholesterol does not tell the whole story as much as HDL and LDL. When it comes to HDL, generally less than 40 is low, 60 or more is high. Triglycerides, you can see the scale here. Normally it's less than 150, 500 is significantly high, but triglycerides haven't been so much linked to heart disease as have LDL and HDL. So how do we decide somebody's goal? If you look at your labs, it'll just say anything 100 or above or triple digits LDL is abnormal, but that doesn't tell the whole story because we really base it upon how many risk factors you have. So those risk factors to decide what LDL goal you should be are cigarette smoking, hypertension, having low HDL, family history of early heart disease in first-degree relatives, and age and gender. And then in patients who have, again, coronary heart disease or an equivalent, we want to get their LDL at least less than 100, and in some cases less than 70. So equivalents of coronary heart disease, so other than people who have already had stents or bypass surgery or a heart attack, would be people who have peripheral vascular disease, so atherosclerosis that's severe, typically in the legs and the arteries, okay? Or even in the aorta, in the abdomen. Although I would include carotid artery disease, which is a similar form of atherosclerosis in the neck arteries that supply the brain and can lead to stroke. Anyone who's had a stroke is going to be treated with the same goals as heart patients, and diabetes. And I would probably add to that list kidney patients, patients on dialysis. Their main cause of death is cardiovascular disease. So basically, the less risk factors you have, the higher the LDL acceptable goal is. So if you have no risk factors or one risk factor, then we say the goal is 160. I never feel comfortable with that number, and we know that any triple-digit LDL can lead to atherosclerosis, but this is what the guidelines recommend. So if you're at the 160 threshold or above, then it's recommended to try therapeutic lifestyle changes. But if that fails to get you there, then treatment should be considered. And if you're above 190, the recommendation is to start treatment even if you have no risk factors. If you have 2 or more risk factors, the goal drops to 130. And again, if you have coronary heart disease or its equivalent, the most common equivalent that we're going to see is diabetics. Your LDL goal is 100. So if we look at the risk of developing coronary heart disease in men, in this case specifically from the Framingham study, this is a 4-year follow-up, patients aged 50 to 70. You can see varying degrees of risk based upon both LDL cholesterol, which is the axis down here, so low 100 LDL, high 160, and extremely high 220. And then it's going to break it down based upon HDL levels, where yellow is the lowest HDL, which is bad, and blue the highest. You can see that the blue bars are a lot shorter. So even at high LDLs, the HDL is quite protective and keeps the risk very low. But that's not to say that the LDL doesn't matter just because the HDL is high, because still the relative risk from a person with 220 compared to a person with 100, the same HDL, is a triple the risk. But certainly it's the combination of lower HDLs and higher LDLs that provide the highest level of risk. So that's what I wanted to say about cholesterol. So moving on to the next risk factor, which is diabetes. Obviously, diabetes is a complex disease. So diabetes occurs because of a problem with the uptake of glucose. So normally when we ingest carbohydrates, that gets broken down by the intestines and absorbed into the bloodstream. Our pancreas releases insulin, which then causes the sugars we call glucose to get taken up by the cells in the body, which it then uses for its energy. And the remainder glucose gets stored in the liver and muscles. So normally, without diabetes, you can see that insulin is like a key. These keys represent the insulin in the body. These particles are the sugars, the glucose. And they can enter the cell because the insulin acts like a key to unlock the cell to allow the glucose to transport normally. When you have diabetes, there's a problem with that system. In the case of type 1s, they don't have insulin. They lack the keys to open the doors to the cells to allow the glucose to be absorbed. In the case of type 2 diabetes, the insulin may be decreased, but the key doesn't fit either. So there's a problem with this receptor or the keyhole. So I don't want to talk too much about type 1, but briefly, the pancreatic cells that produce insulin are destroyed, and therefore we have to treat those patients with insulin exogenously. The age of onset is usually in childhood or young adulthood, and it's the most common type of diabetes in children and adolescents. Type 2 accounts for 90% of our patients. It usually occurs in people over the age of 40, and the majority of those patients are overweight. This is a growing problem, along with the growing problem of obesity in our country. So in the type 2 diabetes, you have insulin, there may be less of it, and there's resistance to it. So the tissues do not respond normally, and this results in hyperglycemia, which just means high blood sugar levels. There is decreased but not absent production of insulin. Therefore, our therapies target the responsiveness of receptors in cells to insulin and or the production of insulin in the pancreas. So in type 2 diabetes, the onset is gradual. Patients can often go undetected for years, and the levels are markedly elevated when we make the diagnosis. We consider a patient to be type 2 diabetic if they have a fasting blood sugar of 126 or more. So this is again looking at the Framingham study, and basically what we're seeing is that if we compare diabetics to non-diabetics, there's a substantial increase in risk of cardiovascular diseases. For example, a 1.5-fold increase in men for coronary disease, 2.2 in women, 2.9 for men in stroke, 2.6 in women, 3.4 for peripheral vascular disease, a 6.4-fold increase in risk of peripheral vascular disease in women with diabetes. Heart failure, a 4-fold increase in men, and a striking 7.8-fold increase in women. And all cardiovascular events are increased by 2.2-fold in men and 3.7-fold in women. The absolute numbers are higher in men, but because, as you saw on the other slides, that the men in general tend to have higher cardiovascular disease, it seems that the women have a lower baseline and a greater jump in level of risk with diabetes. So this essentially, again, demonstrates that from the Framingham study, similar to my previous slides, but comparing in this case diabetics to non-diabetics, both have an exponential growth in risk as you increase other risk factors, but across the board, the diabetics are substantially at higher risk. And this is a growing problem, as I mentioned, and we expect that nearly 592 million people will have diabetes by 2035. And 65% of deaths in diabetic patients are due to cardiovascular disease. The stroke risk is increased 2 to 4-fold, heart failure 2 to 5-fold, coronary heart disease deaths 2 to 4-fold. So moving on now to smoking. Approximately 1/3 of smoking-related deaths among Americans are related to cardiovascular disease. Male smokers die on average 13 years earlier than their non-smoking counterparts. Females, 14.5 years earlier. Smoking is a very powerful independent predictor of sudden cardiac death in patients with coronary heart disease, and it results in a 2 to 3-fold risk of dying from coronary heart disease. This slide essentially is showing you that there is markedly increased 14-year rates of coronary heart disease risk in the Framingham study, looking at men under the age of 55 compared to non-smokers. And that's on the left looking at coronary heart disease in general, and on the right it's looking at heart attacks. So a lot of people smoke, and at one point, this is older data, 50 million Americans, that number may be higher now, I'm not sure. 50% attempt to quit annually. we probably need to do a better job as doctors educating these patients when they have a heart attack on smoking cessation, either both at the time of discharge and also in outpatient follow-up. We probably could treat these patients more aggressively with tools to help them quit smoking. At one point, it was estimated that the direct and indirect medical costs for smoking are $130 billion annually, and again, that number is probably higher now. So this just shows an older slide, but older data, but shows that nearly a quarter of patients dying from cigarette smoking are attributable to coronary heart disease. Over a quarter can be attributed to lung cancer, less than that to chronic lung disease, and the remainders are due to other cancers and strokes or other causes. So 1 in every 5 deaths from heart disease in the United States is related to smoking. On average, smokers die 7 years earlier than non-smokers, and obviously the majority of these causes of death are related to cancer and heart disease. The general surgeon had labeled cigarette smoking as the leading preventable cause of disease and death in the United States. Smoking increases the risk of blood clotting. It can raise blood pressure, as I mentioned before. It can reduce exercise tolerance, probably predominantly through its effects on the lungs. And it can also affect cholesterol levels, and that can play a big role. So when patients smoke, it actually lowers their HDL and it increases their LDL. So both negative consequences that increase the risk of cardiovascular disease. And this slide basically says some of the same things I've already mentioned, that smoking is a powerful cause of atherosclerosis. Much like the other risk factors, it promotes damage to the endothelial lining of arteries, promotes lipid deposits and plaque formation, and therefore it along with diabetes are probably 2 of the most heaviest risk factors that we see out of these factors leading to heart attacks. So I think I've already mentioned most of these things already. This kind of reiterates what I've already told you. There are many harmful chemicals in cigarettes. Obviously, the most harmful products are nicotine and carbon monoxide. So nicotine, unfortunately, is a very addictive substance. It can speed up the heart rate, it can raise blood pressure, and it can constrict arteries. Carbon monoxide can rob the heart from oxygen, and when combined with nicotine, it can increase blood clotting and hardening of the arteries, on top of the fact that they're carcinogenic. So I did have a few slides here on e-cigarettes just because that has become something more popular as of late, but I think in the interest of time, I will skip over that. And the bottom line is that e-cigarettes are not any better. They don't help quit smoking. They are harmful. And nicotine really has been used in the past as a pesticide and causes poisonous effects in insects. So yet we use it for pleasure. So the bottom line is that in order to live healthy, to prevent cardiovascular disease, don't smoke. Eat heart healthy, low sodium, low fat, low carbohydrate. Stay active, not sedentary. Exercise regularly. Keep the weight down. Control the blood pressure aggressively with your doctor through both medications and lifestyle. Control cholesterol the same way. Do see your doctor regularly and screen for risk factors and talk to your doctor about your risk factors and manage your stress. Don't worry, be happy. Thank you. I'll take any questions.
Sir. What is your recommendation on low-dose aspirin?
Yeah, so this has gotten a lot of media attention. The question was, what is my recommendation on low-dose aspirin? So they actually just had a recent meeting by the American College of Cardiology, and they released a statement basically saying that, and we're talking about primary prevention. So primary prevention means a patient who does not have cardiovascular disease. If you have cardiovascular disease, you have to take aspirin. It's preventing a second stroke or a second heart attack, for example. But in patients who don't have cardiovascular disease, the concern is that aspirin isn't benign. It does increase the risk of major bleeding and ulcers. And so if the risk outweighs the benefit, we don't want to use it. So the concern is that elderly folks are going to be higher risk of bleeding. So they're not promoting the use routinely, at least in patients over 70. And in patients that are middle-aged, they say it's a class 2B indication. So we can look at classification of, thank you. The classification of recommendations based on guidelines are class 1, means there's overwhelming evidence everyone should follow that. Class 3 means there's potential for harm or no evidence and it shouldn't be done. Class 2A is there's pretty good evidence and most of the time we should do it. Class 2B means there's lacking evidence and it's controversial. It's not wrong, but it's not clearly a benefit. So they've dropped aspirin as primary prevention in middle-aged folks to 2B. So, you know, I think oftentimes the pendulum swings too far one way or the other. So we want to tell everybody to take aspirin and then we want to tell nobody to. But the reality of it is we need to be more conscientious about these decisions. And we want to identify the patients who are at highest risk. Obviously, you can tell from these slides, there are a lot of other ways besides aspirin that we can prevent cardiovascular disease and events. And so that should be our main focus. But I'm hard-pressed to think that a patient who has every Framingham risk factor shouldn't be on a prophylactic aspirin. So I think it's going to continue to be something we look at and redefine, but certainly nobody should take aspirin without consulting with their doctor. And you have to understand that whatever decision you personally make with your doctor is not going to be the same for every patient. It's going to be an individual decision. I hope that answers your question. Yes?
If you're on a blood thinner,
Yes.
should you be taking that aspirin?
The question is, if you're on a blood thinner, should you be taking aspirin? In general, the answer is no. When you take a blood thinner plus aspirin, you're increasing your risk of bleeding. And in general, the benefit is not going to outweigh the risk in most patients. There are some rare exceptions. The main exception is going to be patients with mechanical heart valves. In general, mechanical heart valves, it is recommended to take both a blood thinner and an aspirin, but most other patients should not mix the two. There are other rare exceptions. If I put a stent in somebody who needs to be on a blood thinner, I do need them to be on, usually I'll put them on Plavix for 6 months for the stent, and then stop the Plavix. And I won't usually put them on aspirin. So it'll be just Plavix plus Coumadin or Eliquis or Xarelto or Pradaxa, depending on which blood thinner they're on. So,
What about if they've had a clip in the heart valve?
a mitral clip.
Yes.
So the question is, what about if they've had a mitral clip? There are certain situations with certain structural heart treatments, be it mitral clips or transcatheter aortic valve replacement or other structural heart disease procedures that we do where you may be told to temporarily, kind of like a stent, mix an antiplatelet and an anticoagulant, but it should never be long-term. It would only be temporary. But definitely, of course, if that comes up, if you have a procedure like that, you have to go with what your cardiologist is telling you. But if it's 6 months or a year beyond some kind of procedure, then you have to have a serious conversation with your doctors about whether it's safe to continue to take more than one blood thinner. Other questions? Yes?
Could you speak a little bit about statins?
Sure. Okay, well, so you're right. I didn't really talk about statins, but we talked about cholesterol. So the primary treatment for cholesterol is statins. Why? Because they are the most powerful, I would say, pill form of treatment that we have to target LDL. So they're going to give us the best results in lowering the LDL, which is the main target for us when we treat cholesterol. And in addition to that, statins have been shown to have anti-inflammatory effects. So those effects can reduce the inflammation that's the fundamental of atherosclerosis. So to date, statins are the most powerful way to directly attack atherosclerosis. We don't know that we have those same anti-inflammatory benefits from any other drug. It's never been shown with any other cholesterol treatment. We do have newer treatments called PCSK9 inhibitors, which are injectable medications, which are used sometimes in lieu of or in conjunction with statins. But even for those drugs, which are even more potent at lowering LDL, we don't know that they have those anti-inflammatory properties. So there are a lot of statins commercially available. So most of these patients, we're going to start off with some form of a statin. And statins, particularly in patients who've already had cardiovascular disease, specifically strokes and heart attacks, or stents or bypass surgery, we really want them to be on statins because we've shown scientifically that they're very powerful at preventing future events and need for future procedures. Now, statins do get a lot of media attention as well. Some people are very apprehensive about taking statins. I think a lot of that is definitely blown out of proportion. Statins are very safe, but they do need to be monitored with your doctor. So we have to monitor your liver tests. We have to monitor for any side effects you may feel, like muscle aches or pains. Unfortunately, a lot of folks don't tolerate statins, and when that happens, we have to try different doses and different ones, and if that fails, then we can consider other options. But if patients are taking statins and they're not feeling any side effects and their blood tests are stable, then they're very effective and very safe, and certainly the cornerstone of our treatment. Okay? Yes?
Is there a risk of developing diabetes when you take statins?
I do not believe that statin...
That's right.
Yes, thank you. The question was, is there a risk of developing diabetes if you take statins? I would say no. I'm not aware of such a risk. I'm not seeing that statins are causing patients to develop diabetes or having to take more diabetic medications if they have it. In fact, some of the largest trials of statins were studied in tens of thousands of diabetic patients, and it had a profound benefit in reducing cardiovascular risk. So, generally speaking, in diabetic patients, we're looking for excuses to put them on statins because, as you saw from the slides, those patients are some of the highest risk for events, and that's why we treat them as a coronary heart disease equivalent. So if you're diabetic, we want your LDL to be 100 or less, and unfortunately most people are not able to get there without treatment in most cases, and the most common treatment again is going to be a statin. Other questions?
You haven't mentioned anything about atrial fibrillation.
I did briefly mention, the question was, I didn't mention anything about atrial fibrillation. I wanted to focus on the risk factors that lead to heart disease, and atrial fibrillation itself is a form of heart disease. I didn't talk a lot about what leads to atrial fibrillation. I mentioned it briefly in one of my slides on strokes, but basically atrial fibrillation is an irregular heartbeat. Oftentimes it's fast. It comes from an electrical storm in the left upper chamber of the heart. and originates from where the veins that bring oxygenated blood back to the heart attach to that chamber called the pulmonary veins. And it is the most common electrical abnormality that we see in the heart, or most common arrhythmia. And the main risk of atrial fibrillation is the risk of stroke. So patients who have atrial fibrillation, if they have other risk factors such as age, blood pressure, diabetes, previous strokes or TIAs, and gender, then they need to take blood thinners like some of the ones I mentioned before. And the risk factors for developing AFib are essentially age and high blood pressure are the biggest risk factors, but lung diseases, any acute illness can lead to it, coronary artery disease can lead to it, things like that, and valvular diseases can lead to it as well. So we had a question over here. Yes?
Are you seeing an increase of coronary disease with sleep apnea?
I would say that sleep apnea has a lot of...
Question?
Yes, thank you, Joe. The question was, am I seeing a lot of increased coronary artery disease with sleep apnea? I think that's hard to say because coronary artery disease is very prevalent and so is sleep apnea. So you're going to have a lot of patients that have both, and it's hard to know necessarily the cause and effect. But in general, we don't think of that as being a strong connection based upon our scientific literature. There is a strong association on the last question between sleep apnea and atrial fibrillation. That's been very well described. Not so much, though, a direct correlation necessarily between sleep apnea and coronary artery disease. Question?
Is there any difference or hierarchy in effectiveness in high blood pressure medicine? Some of them are pretty old, and are there better ones now?
So the question was whether there's any hierarchy of blood pressure medications in terms of which ones are better based upon newer or older drugs. I would say no, because in general, there's such high variability from patient to patient as to what effect we might see when we give them blood pressure medication. And so I don't think that there is any kind of paradigm shift or anything in terms of blood pressure medications over time, that the newer ones have discovered something that we didn't know about before and are somehow more effective. So literally, I could gather a group of my patients that will swear that certain classes of medications are better, and that can corral a bunch of other groups that totally disagree, and just based on their own personal experience. But in general, there are essentially 4 basic blood pressure medicine classes that we try to start with in all patients. And that's based upon a lot of data, including the ALL-HAT study, which was one of the landmark hypertension studies that proved their safety and efficacy. And a lot of those medications can be taken once a day, which is easier. A lot of the older medications, or when we have to go beyond those basic 4 classes, may be shorter acting, maybe need to be taken more frequently, or have other kinds of concerns. But the major 4 classes of blood pressure pills that we like to start with are ACE inhibitors and angiotensin receptor blockers, which we kind of group together. They both are involved in the hormone axis involving the kidneys, the renin-angiotensin system, if you will. So that's considered one class, and oftentimes the first-line choice. So those would be your medications that end in pril for the ACE inhibitors, like lisinopril, benazepril, enalapril. And for the ARBs, those are your sartans, so your losartan, valsartan, olmesartan, and so on and so forth. And then calcium channel blockers, oftentimes the pine medications like amlodipine or nifedipine. And then also thiazide diuretics, most commonly hydrochlorothiazide. And finally, beta blockers. We love beta blockers in cardiology. We use it for coronary artery disease and congestive heart failure. It has a lot of benefits in known cardiovascular diseases. So your beta blockers are your medications that end in all, like atenolol, metoprolol, etc. Other questions? Yes, sir.
What role does hydration have in heart rhythm?
The question was, sorry, go ahead.
That's it. I
Okay.
was just wondering if it had any effect.
The question was what role hydration has in heart rhythm and if it has any effect. I would say that in general, I wouldn't expect hydration to affect your heart rhythm. The heart rhythm really means where the origin of your heartbeats is coming from. So an arrhythmia is when your heart beats out of the natural rhythm. But definitely hydration can affect your heart rate. So if you become dehydrated, you're more likely to have a faster heart rate. And patients who get dehydrated, let's say I'm standing up here for this entire talk and I'm totally dehydrated, I could pass out. So that is a not terribly uncommon mechanism we call like a vagal episode. So that's an adverse outpouring of the vagus nerve that causes a sudden drop in blood pressure and heart rate. So patients who are prone to that, we tell them to stay well hydrated, and if they don't, they could have a drop in heart rate if that mechanism arises. But I wouldn't expect hydration to have a major role in heart rhythm, with some exceptions. In a patient who has cardiovascular disease and heart failure, if we over-diurese them, meaning we get too much water off and dehydrate them, they may be more likely to develop an arrhythmia. Or likewise, if somebody gets volume overloaded, so the opposite of dehydration, but retaining water, which is, if it's due to the heart, we call it congestive heart failure, then they can develop arrhythmias from that. But in the absence of those diseases, I wouldn't expect it to. Other questions? Okay, thank you very much.